For this panel, we'll be discussing the road to health equity in bladder cancer, and I wanted us to frame it in this way because we don't have a solution in any space, really, but there's amazing work going on both inside bladder cancer and outside that we can use and adapt to improve care and systems level change within this space. So it's exciting. Thankfully, many people who are current mentors, or I hope to pick their brains in the future, are here to talk about their work. And I hope to plant the seeds of collaboration and ideas for what could be done in this space, given what amazing work is already being done outside of it. So I'm Samuel Washington, Assistant Professor at UCSF, Epidemiology and Urology. So I'll really be going over the aims of this talk, background definition, conceptual frameworks, and then we'll really dive into the speakers and the research that they're doing and how that can help inform the next steps for us in this space for our patients. Now overall, the goal of this really is to establish a starting point in how we think about equity in bladder cancer and how it may be different than we currently frame it in the literature. And it's really to draw again from expertise both within bladder and outside for how we can do this better. Now, I always bring it back to just simple definitions. When we look at people, we don't define them in one characteristic. Their race, their gender, all these things impact one another. None of them are independent, despite how we present them in papers. So we really have to understand why all of these things exist and how they all work together to lead to the outcomes that we report. So I always like to start with just a clear definition of disparities. It's really a numbers thing. There's a difference in numbers. You can have disparities between left and right-handed people. I used to say between pizza and taco lovers, but that got very heated, so we'll not go down that road. But we often phrase this in terms of racial disparities in cancer care, but it's not limited to race. It's based English proficiency, region, sexual orientation, gender identity, disability. There is no paradigm in which there's not a disparity. It's just we artificially carve out a section to look at. And when we start to frame it like that, everything else falls into place. Now, context is the key, and that's often missing. We approach these questions by isolating these things out of context and seeing that there's a difference. But particularly when we talk about equity in the healthcare system or racial disparities across any situation, we have to talk about where these things persist and exist within the healthcare system relative to housing or zoning restrictions, relative to historical implications of things that happened, relative to geographic location, as well as law at all of the different levels that impact us. So context is really necessary for us to understand care. And that always brings me to the actual definition of social determinants of health. We use certain terms in our literature to mean different things, but these were defined, thankfully, before I was born to describe conditions in which people live, work, play, and exist. It's not just the patient's income or insurance, although those are things that we can easily measure in a cancer registry. These are the situations in which people live, and the downstream effect of these conditions and situations are what we're observing. And a subset of those observations are within bladder cancer. So when we start to change how we think about all of this, it really changes the areas that we should be focusing on. And you move from one area, which is just the patient, to all of the different levels that impact their care and their life. Now we know for bladder cancer, gender is something that is impacting care. We know that there are differences by gender when we look only at that one variable. It is recognized as a factor associated with healthcare outcomes by the World Health Organization, and we know that roles and norms associated with gender in that definition have social implications. Similar things that we see in other areas we are also seeing in bladder cancer in terms of presentation, disparities in care, survival differences. Similar to what we're seeing in race. Again, a social construct of how society and the environments impact this person who is defined by a definition that is not always linked directly to biology. So we have to understand how care differs based on these definitions within the society in which we live. And we have to understand that these definitions are not independent. So if someone asked me to describe myself, I would not say I am a man. I would not say I'm just a urologist or a novice gardener. I would bring all of those things together. And it's the layering of these things that leads to different outcomes. So you have to understand how all of these things interact to have any idea of how we can move from observations, which we've been doing for the last 30 to 40 years, to action. And that intersectionality in one aspect is what we see in bladder cancer, when race and gender come together and we see differences for women. Now, these are contexts and ideas that have been around for a very long time, but again, penetrance into our space has been limited over the past few decades. So I like to bring that up, particularly when we're talking about equity, because it depends not just on the person, but all of these other contexts as well. And I feel like we've all seen some variation of this picture at some point when we have this discussion of what equality versus equity versus justice looks like. But the question is really, how does that translate into bladder cancer? And what does that actually mean? And I think that's the biggest question. And I wish I had that answer. If I had that answer, I'd be retired, right? We'd all be done and everyone would be happy. But I'm glad we're working towards that. Now, how do we think about this in a way that makes sense and acknowledges those levels? Well, there are many different frameworks or ideas or concepts, ways to approach these problems. The one that I've been always taught by my mentors is to look at this by the different levels. We consistently focus on the patient level genomics, patient level income, education. And sometimes that means talking about a system level problem without acknowledging that we exist and work within that system. And that's not just healthcare, that's law and everything else around it. Regional law, regional policies. So when you start to acknowledge all of those other levels, that's when it gets fun from a statistics and nerd standpoint, but more complicated in terms of real life applications of how we can use this, or even understand why it exists and why it may vary depending on the person, where they live, and who they receive their care from. So that really becomes, what does equity look like at each level? And then what does that translate into for each person? So I hope to use that as a way to set the stage for everyone that is coming and speaking about their amazing work, that are doing things in these different contexts. And we start to think about how all of these things merge together within this space of bladder cancer to improve care for our patients, because they're not independent, but it's easier for us to study them in that way. But we have to pull it back and realize, real world, all of these things are existing, all merged together in a sloppy way. So I would have everyone just think about it. What does equity look like at each level for the patient? From a biology standpoint, from a care standpoint, what does it look like in terms of the healthcare provider and the healthcare system? What does it look like in terms of regional policy? And there was recently a paper even showing that based on which county you live in your race, very different rates of mortality. So I think these concepts are starting to push through. People are acknowledging these. So I'd like us to be kind of at the forefront of this compared to other disease states. Right. And I will just briefly go over these other areas where you can start to see all the different things that come into play. I won't belabor the point anymore for any of these, but these are all areas where people have focused on one thing, but at sometimes losing the forest for the trees and how all of these other things exist and interact. And I'll just lastly just say, are our current measures sufficient? So we commonly use race and ethnicity interchangeably, particularly in data sets, where sometimes we're talking about biology, sometimes a racial construct. We talk about insurance, but that's really insurance coverage and then out-of-pocket costs. Education we use as a proxy for health literacy, but we know that those two are not equal. We even talk about employment status, household income, comorbidities, and access to care. But again, I would just caution everyone, anyone in a data registry has gotten access, they've gotten diagnosed. So we're really trying to look at quality of care, but again, using imperfect measures. So I think it's an opportunity for us to challenge the way we've been thinking about all of these things. So hopefully we can do that with the people talking after me. Perfect. Now we have 4 speakers today. The first one up is Dr. Stephen Williams. I want to make sure that I have all of his titles correct. So he's a urologic oncologist at UTMB. He holds several different leadership positions, as well as Associate Chief Medical Officer, Medical Director of High Value Care, tenured professor, Chief of Division of Urology, the Robert Earl Cohn Professorship in Urology, as well as Director of Urologic Oncology and Urologic Research, University of Texas Medical Branch. He'll be speaking to us virtually about his work. He does a lot of different work focused on the impact of urology, comparative effectiveness, as well as variations in care for at-risk patients with bladder cancer. So we'll have him speak first.
Well, thank you, Sam, and members and guests. I appreciate you all for allowing me to participate in this very meaningful, event. I'm going to be sharing my screen right now, so Hopefully all this goes seamless. Okay, can everyone see the screen? All right, so I'm going to be discussing the road to health equity and bladder cancer in the current state. Bladder cancer, this is just a brief review of the statistics. The estimated new cases are almost approaching 170,000, where there's approximately 32,000 deaths, which is a male predominant disease, as Dr. Washington did elucidate earlier. However, what's interesting as well is that, while being a male predominant disease, it's the fourth leading new case diagnosis among males and the eighth leading cause of death among males. However, bladder cancer incidence and survival by race, which is very interesting, is not elucidated by race in itself. It's not described at all. However, for all cancers, cancer incidence is highest among whites, followed by AIN as well as then blacks. So why is this? Bladder cancer is historically an orphan disease, as many of us know in this room. In addition, there's a lack of interest versus finding the cure. And really, there's a lack of social determinants of health. The impact in research really dedicated as well in this arena, but also health services research is lacking overall. And through numerous recent efforts, there's a number of investigators that have provided some really meaningful insight, and provided also too, and elucidated an opportunity to stimulate others in this arena. However, when one looks at bladder cancer disparities research, really it's only had a more recent, interest or surge, if you will, with 379 articles, and this time period is from 1975 to 2023. However, when this is compared to prostate cancer, we have almost 2,000 articles over a similar time frame. So you can see there's a tremendous opportunity, although we're having an increasing interest more recent years, tremendous opportunity to understand and further develop ourselves in this field. And no bladder cancer risk factors, as we said, male to female predominance 3-to-1. Cigarette smoking, obviously 50% of cases. Many of us know this is a risk factor, as well as occupation and environmental exposure, approximately 20% of cases. Aromatic amines, our group here at UTMB even described more recent association for oil refinery proximity to bladder cancer among all other cancer types that we investigated. But as we know, aluminum, leather processing, arsenic, so on and so forth. Regarding race, whites have a higher incidence. However, blacks have almost 2 times increase in risk of mortality. However, more often, this is a social construct. And what we need to better understand is whether or not this is a social construct when being reported, or are there actual biological differences by race. And this is a field of interest that our team here, as well as a number of other collaborators, have really worked collaboratively to develop this arena. So differences and disparities in bladder cancer, as we mentioned before, regarding incidence and mortality, blacks versus whites, historically more advanced disease when diagnosed. And regarding social determinants of health, really this definition is critical, and we need to understand, and the healthy people in 2030 have a great definition in regards to conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. But this also really more broadly encompasses in something that we know as access to care, location, geography, zip code, as Dr. Washington elicited, as well as education and income. And these are some of the variables that we have assessed internally within our health services research. But also, too, what we know is low socioeconomic status, as with other malignancies and disease types, result in worse outcomes. And blacks versus whites have more advanced disease and worse survival, as prior noted. However, what's also critical is understanding really race reporting, and our group here tried to better understand this really in regard to clinical trials and race reporting and disparities research when we performed a systematic review. And what was interesting, including studies from 1970 to 2020, about a little over 500 articles, 4.4% only reported race, and only one of the studies actually reported results on this efficacy, safety, and tolerability of the treatment separately for race groups and performed analysis stratified by race. So this really highlights, much work to do in this arena, an opportunity to understand and describe bladder cancer by race, but also too, even more recent, studies that I've come across and have actually asked to be a part of randomized trial. One thing I definitely appreciate from industry is ensuring that when we do have an opportunity to enroll patients by race, and particularly historically underrepresented populations at large. And we need to learn from others. This is a study, that I mentioned here, geographic distribution, race, to understand prostate cancer mortality. And this is done by Dr. Fletcher, who's currently at Johns Hopkins, but this study came out of Brigham and Women's. And what they're able to describe here is really the findings suggest population differences in prostate cancer specific survival by race associated with a small subset, and particularly with low-risk prostate cancer. So I found this of interest because what I always like to do is try and learn from others and understand, and being my focus in bladder cancer, is whether or not there's anything we can learn from this. And so our group also too internally performed a similar type study specifically focused on muscle invasive bladder cancer. As we know, bladder cancer mortality overall increases exponentially once the disease invades the muscle. And what we're able to describe here as well is also very similarly geographic distribution by race, but also too what we noted in regard to, there's tremendous opportunity to understand really the social in the context of social determinants of health, and also to help inform decision making at large. And I think this study in itself, as many of others, just highlight further opportunities where investigators can better understand not only the opportunity to describe our disease, but also too in the context of treatments. This is one of the first studies that I performed to understand underutilization of radical cystectomy, but also we're able to describe, particularly in a more recent context, Dr. John Gore performed a similar study trying to understand underutilization. What we found here particularly is blacks were less likely than whites to undergo radical cystectomy, and blacks were less likely than whites to receive a pelvic lymph node dissection. However, what was not done before that we included was also to urologist density, which we didn't notice this to be an impact our findings, which suggests not only increasing the density of urologists, but particularly perhaps urologists that do provide those treatments they in fact render, which include radical cystectomy, are needed. But once again, this did not impact these findings. Racial differences in radical cystectomy treatment. We also did a specific focus study. This was in SEER only, and we found similar findings with decreased use in radical cystectomy among blacks versus whites. And trends in radical cystectomy use did improve, in more recent years. So now we described it in muscle invasive bladder cancer clinical trials, really the context. And what we wanted to do is also understand whether racial differences in non-muscle invasive bladder cancer also exists in regard to treatment. And what we did here in this particular study, and through a Department of Defense grant, we've been able to cultivate a very large population-based data to understand, bladder cancer. And VA is the largest equal access system in the United States, and from 2010 to 2015 among high-risk non-muscle invasive bladder cancer. Interestingly, we found no difference in age, sex, smoking status, Charles-Lund comorbidity index by race, no significant difference in rates of adequate induction or maintenance BCG according to race, and importantly, no difference in any of the outcomes measured. So it really begs the question, does access to care matter? And in this preliminary study here, we in fact do suggest that access does matter and helps mitigate these differences in treatment. However, also too, what I mentioned earlier, in a hypothesis that I had that really had not been tested before, is whether or not racial differences in bladder cancer biology. And this is a very small select cohort, 26 high-risk non-muscle bladder cancer patients that are BCG naive, matched on age and sex. These were a combination of patients, 2 institutions. One was at UTMB, as well as the other ones from the Durham VA Medical Center. And RNA sequencing was performed for subsite distribution as well as differential expressed genes. And what we're able to identify in this group in both cohorts was class 2A was most common. However, and that tends to portend to an aggressive phenotype, but also too, there are 10 genes linked with progression that were commonly upregulated in African Americans compared to European Americans, including these particular genes in itself. So these findings do suggest, and they're hypothesis generating with continued ongoing investigation to determine whether these findings persist in a larger cohort. We focused on race primarily, but also too, I also wanted to discuss what about female sex. And historically, females present with more advanced disease and lend to worse outcomes compared to the male counterparts. And in this population-based study, approximately almost 10,000 patients, women were more likely actually to undergo radical cystectomy. Interestingly enough, there was no delay to radical cystectomy, but women had worse overall and cancer-specific survival than their male counterparts. So these findings suggest biological differences, by sex, which I know a good friend and colleague, Dr. Seema Porton, has also provided some further evidence to suggest there's biological differences by sex that contribute to worse outcomes among females. So the time to challenge the system is now, more so now than ever before. We have an understanding disparities exist in bladder cancer, as Dr. Washington alluded to. However, we discussed only by race and sex due to the time that's available this afternoon. However, there's numerous other examples where disparities not only by race, but do exist that we need to investigate further, learn and understand. Also, too, we need to acknowledge and inform interventions to mitigate social determinants of health as previously described in the context and the definition described, but also, too, at-risk groups to improve screening, diagnosis, treatment, and outcomes. We need to describe really bladder cancer and bladder cancer research in the context by race and improve efforts to accrue populations in clinical trials which mirror the real world and the patient population that we serve. And the time is now for action and research in motion. This is just a brief description of the large bladder cancer database within the VA that our team developed. Now is initially a 30-person plus team, now is turned into a 100-person plus team. And we call this the Bladder Longitudinal Assessment Database to direct epidemiologic research. And one thing that you can find here, although the VA is a male predominant population, it also too lends itself to really investigating differences by race, which tends to have a larger Black population as well as other populations than what we see in our conventional civilian-based database. So I want to thank everyone for your time, and I'll pass it back over to Dr. Washington.
Thank you again for taking the time out to Zoom with us, go over everything. We'll save questions towards the end, but we will move on to Dr. Scarlett Lynn Gomez. Her work will take us out of bladder cancer into the realm of prostate. She's a professor, Department of Epidemiology and Biostatistics at UCSF. She co-leads our cancer control program within our cancer center. She's also the director of the Greater Bay Area Cancer Registry, which is part of the California Cancer Registry and part of the NCI SEER program. Her research is focused on the role of social determinants of health, including race, ethnicity, socioeconomic status, gender, immigration status, social cultural factors, as well as neighborhood contextual characteristics on health outcomes. She's developed the California Neighborhoods Data System, which allows us to examine small area level data on social and built environmental characteristics and to evaluate the impact of social and built neighborhood environmental factors on disease outcomes. She'll be speaking with us next about her work.
Thank you so much, Sam. I'm going to actually turn off my video because I'm a little bit afraid that my connection might be unstable. So hopefully that will help. And let me go ahead and pull up my slides. Really want to thank Sam and the organizers for inviting me to speak with you all today, and some of the work that we're doing in the space of prostate cancer, but really hopefully we could see how the approach can apply to examining bladder cancer inequities. So I'm going to be speaking about some of the research and approaches that we're using in studying structural and social drivers of health in examining cancer health disparities and inequities research. To sort of set the stage, and Sam's done a really beautiful job with presenting a multi-level framework, defining social determinants of health. I particularly like this schematic framework that came from the Benton Franklin Health District, because I like the idea that it's really lays out and illustrates that there are upstream and downstream impacts upon health, which in turn produces health equities. Sam defined the WHO's definition of social determinants of health. We in our group are trying to increasingly utilize the term social drivers of health, with the idea that our living conditions do not necessarily always define or determine, or not determinants of our health outcomes. So these social drivers of health, as Sam defined, are the conditions in which people are born, grow, work, live, and age. And they are illustrated by this middle part of this this schematic showing the living conditions specifically with regards to physical service environments, economic environments, and social environments. And so as you can see from the backdrop of the mountains, the water that flow down from the mountains, these living conditions shape individuals' health behaviors among those who live within these conditions, and consequently their health outcomes. But there are further factors, or factors further upstream. And so what I did was I parsed out the WHO definition for structural and social determinants of health. What are these structural drivers? These are the wider set of forces and systems shaping the conditions of daily life. Sam also touched on these. These are the social inequities, the inequities with regards to individuals and populations, class, race, ethnicity, immigration status, gender, sexual orientation, as some examples, as well as intersections of these characteristics. These inequities shape the distributions by which the institutional resources are available to populations and population groups. And so how do we implement this in terms of how we do our in terms of how we do our research? So here is one approach. Sam showed a multi-level model. This is yet another multi-level model, one that my group research lab at UCSF most commonly uses. This was proposed by the Centers for Population Health and Health Disparities from which were a series of centers funded through several rounds of P50 grants to society model for health disparities research. So let me just quickly point out to you some of the fundamental features of this model. They define factors, multi-level factors ranging from biologic factors and interactions of these factors as they work together to shape cancer disparities. Importantly, the authors emphasize that there is actually a very important importance of ordering of these factors, such that as we go up levels, they become more important in terms of their impact upon cancer health disparities. So I want to focus now on one example of research that we do in the space of prostate cancer, but we also have a number of different studies in which we're applying this more to other cancers on how do we operationalize the social physical context and these fundamental causes. That is the structural and social drivers of health. So this is a case study of a research program we have in prostate cancer among African American men. I'm sure these statistics are very familiar to this audience. Why do we care about prostate cancer among African American men? Because we see a persistently higher burden of prostate cancer, both in terms of incidence and mortality. And as Sam pointed out, there's been, and Dr. And Bill pointed out, there's been abundance of research focusing on prostate cancer disparities, and they have shown collectively that African Americans are more likely to be diagnosed with more aggressive tumors, But there's some mixed results in terms of what do we see after we adjust for a number of different factors. So some settings in which there are equal access and equal care settings show that after we adjust for stage treatment and some measures of survival outcomes among African American or Black men compared to non-Hispanic white men. But generally in population-based data, such as SEER data, we see continuing disparities. And so a multidisciplinary group and I came up with this, came together and developed this conceptual framework for assessing aggressive disease and consequently mortality of prostate cancer among African American men. We posit that the fundamental cause of the high burden of prostate cancer among African American men is structural racism. That structural racism impacts upon social stressors over the life course at multiple levels. Specifically here, I've delineated factors at the contextual level and impacts at the individual level. These over time, over the life course, produce stress, which is consequently embodied, impacts upon the biology, and impacts upon prostate cancer. These life course social stressors, as a consequence of structural racism, can also impact upon prostate cancer outcomes through other pathways, including healthcare access, health behaviors, and other pathways that's not listed here. And then we know prostate cancer does have a strong genetic component. And so this pathway may be modified by germline risk factors. So putting all this together, the investigators and I proposed the RESPOND study, which is looking at prostate cancer among African American men and specifically addressing the role of social stressors, genetics, tumor genomics, and biology. We have funding primarily from the NCI as a PO1 grant, which is administered as a U19 grant, but also as well from the National Institute of Minority Health and Health Disparities, NIMHD, as well as the Prostate Cancer Foundation. And so RESPOND is an integrated set of studies focusing on this common theme of identifying multi-level determinants of aggressive prostate cancer, specifically among African American men. There are 4 projects within this program project, and I will show you how the 4 projects are laid out. So this is now overlaying the 4 projects onto this conceptual framework. Project one, which my team and I are leading at UCSF, is focusing on the social stressors component of the project. Project 2, which Chris Heyman at USC is leading, he is a genetic epidemiologist, is focusing on prostate cancer risk loci and genetic ancestry. Project 3, which is led by Joan Carpton and Franklin Huang, is focusing on tumor genomic profiles. And Project 4 is looking at the immune factors within the tumor microenvironment. And we are interested in looking at each of these factors independently, but also jointly, so how they intersect and interact to impact upon prostate cancer aggressiveness and ultimately mortality. Going back to this, RESPOND is a national study. Our recruitment primarily is done through population-based cancer registries. So we are recruiting from 7 states and metropolitan region cancer registries, but we also, because of the widespread outreach that we do, we also have a fair number of men who self-volunteer to participate. So we are collecting quite a rich wealth of individual level data on social stressors and different covariates. The men who agree to participate are given a survey, a paper survey. They can also fill out the survey online. And through the survey, we are collecting data on life course multi-level social stressors, including lifetime and everyday discrimination, medical mistrust, adverse childhood experiences, and a specific form of active coping called John Henryism. So I want to note at this point that our approach in collecting, developing the survey items and collecting these data is really to use at the outset, we agreed to use survey measures that are widely used in the social epidemiology field, as well as measures that are widely used in large national and state-based population surveys, with the idea that ultimately, that we can use the data collected through this large prostate cancer cohorts to compare to other existing sources of data. And I forgot to mention that our goal initially at the outset was to recruit 10,000 African American men fairly newly diagnosed with prostate cancer into this cohort. We ultimately were able to exceed that goal and have recruited a cohort of over 12,000 African American men with prostate cancer. We also collected a number of covariates from the survey, including sociodemographic background, healthcare access, family personal health history, details regarding their treatment, and lifestyle factors. What we've also done is we've geocoded the data, their address at the time of diagnosis, in addition to residential history, so addresses associated with where they've lived over their lifetime. And through this geocoding, we are then able to link to a number of different geospatial data sets. Our main measures of interest are in looking at structural racism. We have 2 measures of structural racism that we are looking at. These are developed using a really innovative approach developed by our colleague Kirsten Beyer from the Medical College of Wisconsin. And so what she's done is she's taken data from the Home Mortgage Disclosure Act, which is contemporary data that is basically a database of every single application for a home mortgage loan, basic sociodemographic characteristics of the applicants, and the outcome of that mortgage loan application. So using that information, Kirsten developed 2 measures that are meant to measure structural racism. First is a measure that she calls the redlining index. What the redlining index is a measure based on a multivariable model of the odds of mortgage loan denial for a given neighborhood, specifically a block group or a census tract, relative to the odds of mortgage loan denial in the regions just outside of that neighborhood. So how much more likely is a neighborhood to see higher rates of mortgage loan denial? The second measure is an index of racial bias in mortgage lending. And so what this measure is telling us is the odds of mortgage loan denial for a given population group relative to another population group within that given neighborhood. So our interest here in the measure that Kirsten has developed for us for the response study is an index of racial bias in mortgage lending, comparing African American or Black applicants to white applicants. And again, both of these measures are multivariables, so they adjust for a number of different factors within the model, including sex, income, and the amount of the mortgage loan. We also have a number of different contextual level data or neighborhood level data that we're looking at that I've listed here as well. And so kind of just to jump quickly to some of our results, this is from the first aim of our project 1 that we're leading at UCSF. This entirely comes, so the results that I'm going to be showing you here firstly entirely come from cancer registry data of the states that are participating in Respond. So what I'm showing you here is the distribution of the redlining index comparing non-Hispanic white men to African American or Black men diagnosed with prostate cancer from each of the Respond states or metropolitan areas. If the value of this redlining index is less than or equal to 1, that means that the patient lives in an area where there is a equal or lower rate of mortgage loan denial relative to its surrounding area. So we don't see higher rates of mortgage loan denial in their specific neighborhood relative to its surrounding area. And so what we see here is a pattern that's fairly consistent, although the difference between white and Black men or patients do differ somewhat across the regions, is that white men are much more likely to live in regions where there is a lower odds of mortgage loan denial relative to Black men. We then were interested in assessing the association of this redlining index with survival or mortality after a diagnosis of prostate cancer. The way that we created these models is that we acknowledge upfront that the impact of redlining is likely to be different by race. And so we created an interaction, if you will, between race, that is Black or white race, by redlining. And what we see, and we also saw different effects across the different respawn regions. So we created different models for each respawn region. So let me just kind of walk you through the result here for California. So the reference group here is right here, non-Hispanic white patients with prostate cancer living in non-red line regions. And each level each dot you see here are increasing levels. What we see here is that increased risk of or higher rate of mortality associated with increasing levels of redlining. Now, these next four groups are among African American men. So this dot here is African American or Black men living in a non-red line region. And what we see is, again, a higher rate, even among comparing Black men in non-red line region to white men in non-red line region. Already we see a 50% higher mortality rate and increasing trend associated with increasing rates of redlining. So Black men living in the highest level of redlining have over a twofold higher mortality rate compared to white men living in no redlined areas. So hopefully that's fairly clear. And as you could see, we do see slightly different results across the respawn regions. I didn't show the graphs for the other respawn regions, but they do look slightly differently. So this is the second index of structural racism that Kirsten developed for us. This is the racial bias in mortgage lending. So just to remind you what this index is telling us is the odds of mortgage loan denial for a Black versus a white applicant in the neighborhood that they live in. So it's really a reflection of the degree of disinvestment within that neighborhood. And I want to emphasize that this is contemporary data. So this is not historical redlining, but this is our racial bias, but this is current day, based on current day home mortgage loan disclosure data. And so if the value is this darkest bar, if the value is less than or equal to 1, that means that the neighborhood that patient lives in has a lower or equal odds of mortgage loan denial for Black versus a white applicants. So what do we see? We see that generally very few men across the board, whether you're Black or white, live in neighborhoods where there is no racial bias in mortgage home applications. And in fact, the vast majority of regions generally have a higher rate of mortgage loan denial for Black versus white applicants. And again, these are multivariable estimates are already adjusted for income to mortgage loan ratios. So for us, this was sobering and I'll just say highly distressing to see these kinds of results. Interestingly, and this seems to be playing out in the literature with researchers looking at other health outcomes, we're not really seeing an association with prostate cancer outcomes of this measure of mortgage loan denial. And I'll just stop there and just say that we're looking into this further and just kind of trying to understand this further. And I want to just quickly show you a few of some of the other descriptive data that from the survey data. So we just wrapped up our survey. But we're still cleaning the data from the last few surveys that we received. So this is based on an initial subset of about our first 8,000 African-American men diagnosed with prostate cancer, the surveys that they filled out. This is one of the measures. This is the everyday discrimination. And what we've done here in order to capture life course exposures is to take the Williams everyday discrimination scale, which asks in your day-to-day life, how often have any of the following things happened to you? We made it specific to race ethnicity because we were specifically interested in capturing discriminatory experiences as a result of race ethnicity. And then we adapted this question to ask about different life periods. So current, but also early adulthood and childhood. And this was interesting because what the results revealed to us was that generally for all of these subdomains, they reported higher experiences of percent, this is the percent reporting sometimes or often, in childhood, and generally goes down as they over the life course. And then this is the major discrimination scale, again, from David Williams. So this question asks, in the following questions, we're interested in your perceptions about how people have treated you because of your race, ethnicity. This was also sobering because the percentages reporting yes generally were high in terms of each of these different domains. So we are in the process of trying to work through a lot of data, but I think that it presents an interesting but also challenging issue that we, I think, as epidemiologists and bioinformatics and researchers in general, need to really start thinking very critically about. Specifically in the response study, because we're trying to collect data that pertain to these multi-level models. We have a lot of data. We have data over the life course. We have multi-level data. We have multi-dimensional data from geospatial sources, as well as from self-reports. Approaches that we're using include applying mixture models so that we may summarize all the different measures, for example, to different life periods at the contextual level and at the individual level, but then also being able to apply trajectory models as an example to look across life periods for contextual level stressors and individual level stressors. And of course, all of this requires a lot of people needing to be at the table and what you've heard of as being called a team science approach. And these are just some of the disciplines that we have, of individuals and folks and researchers and collaborators that we've worked with over the years. But of course, the most important of these is really community engagement. You know, we are collecting information on people's experiences and over their life course, and it's just critically important to engage those who are living these experiences to tell us how relevant the relevancy of what we collect and how they may be translated. But so I see a number of opportunities and future directions that we may head into with this kind of research. I think firstly, it's important to recognize that health inequities arise from these fundamental causes. And so therefore, it's important that we then need to incorporate these factors into our research. Data integration, as we've illustrated with the response study of prostate cancer in African American men, is an efficient and novel way to address looking at multidimensional and multi-level structural and social drivers of health. As I've shown with our study, we can creatively use existing geospatially referenced data, as well as make sure that we are incorporating information on life experiences over the life course. We also really need to start move into investigating the impacts of these structural and social drivers of health on biology, specifically to examine how stresses due to these stressors can get under the skin and become embodied and produce cumulative effects. And as Sam also noted, it's important to acknowledge that our models currently are fairly limited in terms of being able to study, to do studies of intersectionality. That is the joint impacts of multiple marginalized structural and social determinant statuses. And I think where at least our group has come to is that we really need better methods in our toolbox. Our current toolbox of analytic approaches is fairly limited in terms of really being able to effectively study how all of these multi-level factors interact together. And then I'll just close with this. This is my favorite quotes in terms of health equity from colleague Paula Braithman, who says health equity means social justice in health. That is, no one is denied the possibility to be healthy for belonging to a group that has historically been economically and socially disadvantaged. And in order to address health equity, we need to be sure that we are addressing the upstream structural drivers of health. Thank you so much for your time.
Thank you again for your talk. I hope to impress upon everyone how data-driven this is, and from a nerd standpoint, very exciting. But I think as we move from understanding what's happening in bladder cancer to understanding how things are being approached in prostate, as one example, moving from social context and where people live and how that impacts biology, we need to dive into that a little bit further. And biology by itself, well, it doesn't exist without the environment in which it lives, but there's more bidirectionality than sometimes we present in the literature when it comes to the outcomes that we're seeing there. So I would like us to transition now to some of the exposures that people may get and how those exposures, particularly in jobs, occupational settings, may impact cancer outcomes. So I'd like to introduce Dr. Koutros. She's a cancer epidemiologist within the Division of Cancer Epidemiology and Genetics within the National Cancer Institute. Her research involves design and conduct of epidemiologic investigations to evaluate occupational exposures as risk factors for cancer.
Can you guys hear me okay? Great, okay. Am I going to the next slide or am I waiting here? Oh, there it is. Okay. Thank you. Okay, well, hopefully this will go forward at some point, but anyway. As Sam said, I am an epidemiologist, and a big part of my research is focused on the etiology of bladder cancer. And we already know, a tremendous amount about the many of the risk factors on the screen here. And their impact on bladder cancer risk, but we really don't know a lot about disparities in risk. I thought I might just share some slides with you just about some of the considerations we've made and some of the things we do know, especially in the context of occupational environmental exposures, because that's a big focus of my research. So first, on occupation. So this is a chart that is available online. It was from a report developed by the Bureau of Labor Statistics, and it just shows the percentage of the different major occupational categories by race and ethnicity. And so some of the key observations from this report included that employed Black and Hispanic men were more likely than white and Asian men to work in production, transportation, and material moving occupations. This is relevant for bladder cancer because we know that these jobs have a higher, have an increased burden of exposure to diesel exhaust and other traffic-related air pollutants. Another statistic that came out of the report was that Hispanics were substantially overrepresented in several detailed occupational groups, that's including painters, construction laborers, and landscaping groundskeeping workers. And again, the range of exposures among these occupational groups includes several known and suspected bladder carcinogens, diesel exhaust again, solvent exposures, pesticides. And Asians also sort of represented 7% of all employed workers, but 73% of manicurists and pedicurists. And so I think anyone who's walked into a nail salon has experienced the waft of the volatile organic compounds that you get sort of in that setting. It's clear, and we know from this report and other work, that workers of color are more likely than the rest of the population to work in hazardous jobs. Whites and Asian men in particular were more likely to work in management or professional or office-based occupations where these kinds of exposures are less common. And so obviously we care about this for bladder cancer because we know that occupational exposures are a huge risk factor for bladder cancer. Up to 25% of bladder cancer is attributable to occupational exposures in men and about a little over 10% for women. And this is just my list of some of the most strongly associated occupational groups and the associated exposures in those groups that we already know very well are linked to bladder cancer. So up until this point, most of the studies that have been conducted on occupation are among white men. Women are also severely underrepresented in studies of occupation. And so we know that we need to do more to characterize occupational exposures in more diverse populations. And so that's something that's clearly on our mind as we kind of move forward in our work. But I also wanted to make a quick plug here for a tool that our group has developed, that can be used by all researchers, anyone who's doing a study and wants to collect occupational information. This tool will allow you to take any free text responses that people have given about what their job is, and it will automatically code it into standardized occupational categories. Then that's what we use sort of as an anchor for some of the main analyses we might do when we're looking for risk factors for bladder cancer. So this is online and can be accessed by anybody. So in my line of work, we kind of mince words and make distinctions between occupation and the environment, which is a little bit silly because clearly many occupational exposures also occur in the general environment, like diesel exhaust. But part of the reason why we do this is because in the way we need to assess those exposures in population-based studies is dramatically different. I would be considered more of an occupational epidemiologist, and so I leaned on my colleague, Dr. Jessica Madrigal, who is an amazing young fellow in our group whose work is really focused on air pollution, and she was nice enough to let me share a few of the slides that on a project that she's working on right now, which is to estimate the population level exposure differences from carcinogens emitted from industrial sources by socio-demographic groups in the US. And she's doing this using census data and data from the EPA TRI database, which collects mandatory emission levels from all of the industrial facilities in the US for a number of years. So this map shows the population burden of exposure to 38 probable carcinogens, and that's based on the designation by the International Agency for Research on Cancer. This is just for 1 year. So the blue dots represent a facility that's emitting at least one of these probable carcinogens, and the orange dot represents higher levels of exposure. And so what Jessica did was also identify the top 5 most highly emitted chemicals. And the top one here is styrene, and she was nice enough to give me some results on this specific chemical because, styrene is a high-volume industrial chemical. It's used in the production of plastics and synthetic rubbers, and from data in the occupational setting, it is a suspected bladder carcinogen, but we don't entirely know for sure yet. So Jessica is interested in understanding, obviously, these differences by race, ethnicity, and poverty. And so this plot shows that among African Americans and Hispanics, there's significantly higher exposure burden to styrene, regardless of SES. And this was not the case for Asians, where the effect was null, but it looks very similar pattern is what you see in whites. And among whites, the increased exposure burden was only evident among those living in poverty. So I think, although this isn't necessarily a result about bladder cancer, I think this is one of the first steps that we are sort of taking to understand the environmental disparities associated with some of the suspected exposures that we care about for bladder cancer. And it's helping us to generate some hypotheses about where we might go to understand sort of the impact of environmental pollutants in the future. Although, as I said, my group does a lot of work on occupation and environment, we also lead an effort to look at the association between common germline genetic variants, so that's variants that are greater than, with a minor allele frequency greater than 1% and risk for bladder cancer, and we just actually published the results from our latest meta-analysis. And in that study, we've now sort of identified a total of 24 markers that have achieved genome-wide significance that are associated with bladder cancer risk. Thus far, this has only been conducted in European ancestral populations, so we are already in the process of expanding the GWAS project to include subjects from other race and ethnic groups. This work is done in collaboration with my colleagues Nat Rothman and Mila Prokunina Olsen. She's here as well. If anybody wants to talk to us about this, we'd love to talk more about it. And this work, actually some of the initial results from the latest round of this project will be presented at the BCAN meeting by Jeff Demrauer, who is collaborating with us on this project as well. So if anyone will be at that meeting in September, you'll get to hear some early results from this project as well. So bladder cancer has, a heterogeneous etiology, and I think we don't exactly know yet the full burden of the risk until we have explored these groups where we know that the occupational environmental exposure burden is much higher. And if we can do that, I know that we will only in the end learn more about the etiology of bladder cancer, and that's what we're aiming to do. So it's just a short overview of some of our work. Thanks.
Thank you so much for the talk. Always exciting to hear. I did want to transition we've gone from kind of population, epidemiologic, and now we're touching upon biology, so I wanted us to touch on that a little bit more. We have Dr. Nicholas Rabin, Director of Computational Biology at New York Genome Center. It's an independent nonprofit academic research institution and a multi-institutional hub for collaborative genomic research. He leads a group of bioinformaticists, analysts with projects applied to cancer genomics as well as functional genomics. Welcome him next to speak on his work.
Thanks everybody. Thanks for the organizer. I'm very pleased to come talk to you today. As Dr. Washington mentioned, I will get you back to where, in my point of view, it starts, which is the genome. And I know for all of you it starts with the patients, and it should benefit all the patients. I hope to demonstrate that what we are doing in a genome center will ultimately benefit a large number of patients. So I'm presenting a project called Polyethnic 1000, which has the goal to advance cancer genomics by studying ethnically diverse underserved population in New York. So the New York Genome Center was founded about 10 years ago, is located in a very nice building in Soho in New York, and is a partnership between many different institutions in New York, really to have a center of expertise in genomics and in sequencing in New York. So here are all the institutions that are in our network that I mentioned, and our three disease areas are neurodegenerative disease, psychiatric disease, and cancer. We have many faculty members that are co-affiliated between some of these institutions and the New York Genome Center, and a large group of staff scientists working on all aspects of genomics, and I'm one of them, leading a group working, as I said, on cancer genomics and functional genomics. We have a large sequencing fleet, mostly Illumina instruments, but we are now having some of the new instruments for long-read sequencing, for other low-cost sequencing technologies. We do a lot of work on single-cell genomics, developing new protocol. Some of you might know CytSeq, to combine single-cell RNA and cell markers. We do some work on single-cell whole genome sequencing, and more recently on spatial transcriptomics. So here is the very technical slides on the bioinformatics pipeline we apply for cancer. Most of the work we do is whole genome sequencing. I'm not going to go into details of all the algorithms that we're using, but I want to emphasize that first of all, we apply this pipeline on many different cancer types, some of them in collaboration with you or with your colleagues. We do some work on bladder cancer in particular with Dr. Faltas at Cornell, but we also work with the NCI, the current iteration of TCGA, and multiple other collaborators. The advantage of whole genome sequencing is that we can obtain all of the germline variants, both single nucleotide variants, copy number variants, structural variants, the somatic variants of the same type, and then we can analyze all of those and decompose into mutational signatures, identify microsatellite instability, do HLA typing, estimate the ancestry, and I will go to that in more details, and so on and so forth. And so there is really a very rich set of results we can obtain from performing whole genome sequencing. So how does that relate to health disparity? The problem that we identify and other people identify in cancer genomics is that most of the large public database that we are using are heavily biased towards patients of European ancestry. Here are pie charts corresponding to the Cancer Genomics Atlas, the TCGA, where about 75% of the patients were self-declared as white. Some of them didn't self-declare, didn't check a box and indicate their race, but very clearly non-white races were underrepresented in the TCGA. We also have on the right side of the slide the equivalent results for AACR Gini, so a much larger set of samples, but still the same problem of a very clear overrepresentation of patients of European ancestry, or in this case, self-declared as white in the US context. The small snapshot that we have here correspond to the genetic ancestry estimation, and you see that there is a good overlap. So we identified this problem, realized that we were in New York, where we are very proud to pretend that we have the most diverse population in the world and representative for from every population in the world, and so we thought we could do something. Now, I want to just give you an example of how that molecular approach can be important. We know that a lot of the disparity, and it's been very eloquently described, a lot of the disparities are corresponding to social, environment, socio-economical factors. Nevertheless, there are some clear differences between population at a molecular level. And here is the cartoon example, the poster child example of that. That's the EGFR variant in lung cancer across population. And you see that around the world, it varies from 10% of the patients with lung cancer have an EGFR mutation to 50% in Asia. And that's really independent of different environment, different smoking habit. It's very strong effect. It's a very strong variation in different population of the frequency of patients that have an EGFR mutation. And so we really want to see in other cancer type if we observe a similar effect or if we find some really strong differences between population. So here is a map of New York. So I hope you recognize Manhattan in the middle, colored mostly in green, corresponding to the white population here. So all of those are coming from the census declaration in 2010, and that hasn't changed dramatically since then. But you'll see the north of the Manhattan Island is colored in orange and blue, corresponding to Hispanic populations and black population. We also have at the southern tip of Manhattan a spot of reds corresponding to Asian, and that's where Chinatown is located. And if you go in the other borough, you also see this very large, very colorful map of all of the different population. So we can look at this map and identify that there is a lot of diversity in New York, and that makes us feel pretty proud. We can also look at this map and identify that there's a lot of segregation and a lot of difference between neighborhood, where a lot of the neighborhood are very homogeneous. And so that's the reality that we are facing in New York, and we can see the same in a lot of the US cities and a lot of cities around the world. So we established a larger network than the New York Genome Center and really tried to obtain samples from the outer boroughs to really try to diversify the database that we are using in cancer genomics. So we did this initial phase where we collected 160 tumor samples from 13 different institutions. All of the participants were self-declared as non-white, and we performed whole exome sequencing on the tumor and RNA sequencing. And the plot that you are seeing, on the right, correspond to the genetic ancestry information. So the top track corresponds to the self-declaration. People came to the hospital, they self-declare Black, Hispanic, Asians. And then we did the exome sequencing, and we can take this genetic information and identify which of the reference population does that associate with the most. And so we have the reference population from the project called the Southern Genome Project, where at the continental level, we have 5 continental levels that we can call superpopulation. And then we have, within those continental population, some distinct populations, and 5 or 6 per continent. And then we can decompose for every sample the association with those populations. And you can see that we have a good overlap between the self-declaration, the race, and the genetic ancestry. But if we look at the patients that are self-declared as black, the proportion of their genome that will associate with the African continents goes from 20% to 100%. And within those populations, you cannot really see in all the details, but there is a really big diversity within the African continent in which population do they associate with. So as we know, there is more genetic diversity within the African continent than anywhere else in the world, and more genetic diversity within that continent than between any individual from Africa from the rest of the world. And so there is the possibility to do all our analysis with the self-declaration race, or there is the possibility to do it with a different analysis that's more complex, that's richer, that's more quantitative, and that's what we are doing with the genetic ancestry. It's still valid to do all the work with race and ethnicity, but we think it's when we have the chance to obtain a very distinct description at the genetic level, that's also extremely valuable. So I want to be very clear, we're not saying that race are a valid scientific concept and are completely corresponding to the genetic ancestry. Race remain a social construct that we can use in our study. In our case, we mostly use it to obtain the samples and enrich our cohort into non-white patients. But for the type of work that we're doing, it's much more valid to use the genetic ancestry information. And so we describe the work that we've been doing in a small essay that we published last year. At the beginning of 2020, we started the new phase of this project. We launched a request for proposal in our network and asked people how that infrastructure that we have in place could benefit their research. And so people wrote some proposal for their particular cancer of interest. We assembled a very nice review board that scored all of those different proposals. We assembled a budget, and we started a project of 1,000 retrospective and prospective samples in 8 different cancer types. And so this is the summary of the results right now. So again, the genetic ancestry estimations. I'm not going to go in all the details, but you can see those samples for breast cancer. So if you go from left to right, from the bladder cancer, then breast cancer, lung cancer, the colon cancer, lung cancer, multiple myeloma, and prostate cancer. So you can see that most of those samples most of those cohorts are enriched for the orange bars corresponding to the African genome. And so really clearly for all of those cancer, we will have a very large number of tumor profile from African American patients. For the lung cancer project in the middle, the bars are green and red, and they're corresponding to Europeans, some from white and from Asians. It's a very unique project that is studying pre-malignant tumors in which we didn't have another cohort to compare to in the public literature. And so in that particular setting, we decided to allocate some of the samples to sequencing white patients. And it's done in Chinatown mostly. And so the study is really on East Asians and European. And where I can tell you that we reproduce the finding that I described earlier on the different frequency of EGFR mutations, but we're also studying other aspects of that. So we have a lot of African American samples, we have a lot of Latino samples, and we're studying that. I know for this audience that it's disappointing that the bladder cancer cohort here is very small. There are very few samples in that particular screenshot, but that's only because I'd made that screenshot a couple of months ago. We now have more samples, and I will describe a little bit more in the next few slides. So we can do the same with mutational signatures. I know many of you are familiar with those. We describe them in three different aspects. The bottom one corresponds to the single base substitution, so the single nucleotide mutations that we can look at the entire pattern and decompose them into the known mutational signatures corresponding to aging, corresponding to smoking, corresponding to ApoBec, or to various known processes. And then we have the dual double base substitutions, and then the insertion and deletion. And so for all of those different patterns, we can decompose them and we can start to study, are we seeing a mutational process that is different in those particular samples compared to what we already know from samples that are predominantly from a white population. So there is no results I can show you right now, but that's really the type of analysis that we are pursuing in all of those different cancer types, and we're starting to see some very interesting patterns. So what do we need now? We need to complete the sample collection, and we're getting close to that. We need to fully analyze and collect all of the results, have as much as possible clinical information, and really the first outcome of this project will be to share all of the data through ICGC Argo, so that the database that will be used in cancer genomics will be a little bit more diverse. And then we are in the process of starting to publish many Polyethnic 1000 papers. We have an abstract indicated here on this slide. And in the future, and the future is probably right now, we hope to expand those existing cohort. We need to do it in more cancer type, in more different populations. And we started to do some patient and community outreach, but definitely we need to do a lot more of that. So just to go back to bladder cancer, and it's a way in which we will expand the cohort and start to go more broad than New York. Many of you might know this map corresponding to the mortality rate of bladder cancer around the world. And the place in the world where the mortality is the highest is Egypt, which I think is something like 6 times higher than in the US. And so we are collecting samples, or we have access to a cohort of existing samples through a collaboration with Chris Lofredo at Georgetown Lombardi to study the samples in Egypt. And as you know, there is a water parasite in Egypt that causes schistocytosis, which is thought to be a contributing factor to bladder cancer. And so we have a sample with and without that parasite, and we are in the process of sequencing them, doing whole genome sequencing, and starting to analyze those results. So this cartoon here summarized the different sources of cancer disparity, was part of an EACR report last year. And so we know and we acknowledge that we're only studying a very, very small part of this large puzzle, that we're really looking at the biological effect, the effect of genetic ancestry, and how the germline genome affects the somatic genome, and how we can learn from studying a particular cancer in a different germline context. What can we learn about those different contexts? We know that there are multiple other sources of disparities, but we really are really intrigued and interested in applying the genomic technology to every aspect that we can study. And so we're looking for collaborators, and we're looking for ideas on what we can do. How can the genomic help to study exposure or to study other aspects is definitely something of interest. So I will close with that. I have a large list of people to acknowledge and to thank, both from my group, from the New York Genome Center, from our steering committee, and the support that we have for this project. Thank you so much.
Great. So I hope everyone's still with us. We went from geography to genome. We went from society down to cell. Each talk may be more interesting to some people than others, but it's the combination that breeds collaboration even in this group. So that's really the exciting point. It's not really that there's any person or one thing at fault, but I just find it exciting that there's so many gaps that we can address. And I hope to impress upon that to everyone here, and how one researcher can't really do it. This is really a team science thing, so we understand what happens on the clinical side, occupational side, environmental side, genomic side, and everything in between. So I'm happy to have anyone ask questions if they like of our team. Maybe. Oh yeah. Oh, if we're able to put our Zoom participants back on as well. Thank you.
I have deferred to Amir first, but he insists. So people were wondering why I'm not asking enough questions. So I wanted to assure them I'm still here. Fantastic session, and thanks, Sam, for putting it together. Great speakers, all of you, and thank you for being to the BCAN family. This is so important to put together the epidemiological aspect and the genomic biology aspect. One thing that really is important in troubling us in the clinical research arena is how we improve upon accrual of represented minorities in clinical trials. And this came up also in the patient voice panel in the first day. So I would welcome thoughts, comments from all of you, how we can utilize this context of the very important data and what I call implementation science with our colleagues in Seattle in order to improve upon that aspect of accrual of represented minorities in trials. Thank you so much.
I guess I can start. Okay. I think it differs depending on institutions. I'm not sure every institution knows what the population may look like in their region. So understanding the populations right outside the walls of our hospitals are important. And then not just, oftentimes we talk about community engagement as an idea or something that we need without acknowledging how long it takes to establish those relationships. So I know within UCSF, that's a long-standing relationship that's been 15, 17 plus years. And now those bi-directional relationships are allowing people to, within the healthcare system, to gain the trust of the people around it, because it's not assumed, nor are we, how should I put this, nor is it expected that we gain that without any effort. Right? So I think that's an active thing. I know within our system it's monitored down to the population level within UCSF, within the clinical trials and the population around us. So that level of monitoring, and then formal partnerships with groups so they understand what we're doing and they tell us what's important to them, helps with recruitment. But I'm not sure that recipe's a one-size-fit-all for everyone, right? The details will vary based on your population, your community, is my take.
Hey, Sam, can I add something as well?
Yes, please.
Where am I in the world? So seeing Petros, I miss you all. I wish I was there, but more importantly, this is such a great question. I think really considering all of us investigators are engaging all stakeholders. That also includes, more importantly, our industry leaders and challenging them, aligning yourself with trials that do have that as a focus in companies, organizations. I'm a global PI for Sunrise 2, and one thing I immediately proposed was that, in doing so and addressing it, and they've created actually a team specifically, reaching out not only to the PIs, but probably the more important is actually the organization itself, and by involving your clinical support team and really addressing an unmet need. To target populations, provide the resources in the manner that they intend to receive it, and opening the door and making it an important initiative. And I think that's critical. Our organization, I'm very, proud. We're a safety net, institution, and it does, really allow itself to increase accrual among patients that are treatment naive, but also to may in fact not even receive any treatment, and it allows them the opportunity to be a part of some pivotal work, but more importantly ensure they're going to be getting treatments and helping answer pivotal questions. So I think it's all of our responsibility, and I found to develop even further really strong relationships, with those that are perhaps some of the most vulnerable in our population. So I challenge each one of us to be a part of those discussions and advocates for our patients.
Hi, Amir Horowitz, Mount Sinai. This is such a fantastic session. Thank you all very much. I have in the spirit of taking it maybe from society to cell, a question for Dr. Rabin. Have you guys been looking at HLA class 1 allelic diversity in your analyses and at very least benchmarking how you're sampling to see if you're truly capturing diversity from the lens of the most polymorphic genes?
So, is it? Thanks. So we are doing HLA typing. I didn't look at the results yet, in particular for bladder cancer, and I'm not sure exactly how we will confirm or what is the expected diversity that we should have. I know we are starting to do it first in lung cancer, but yeah, that's definitely part of the plan. If you have suggestion on how to measure our diversity compared to the expectations, I'm looking forward to discussing that with you.
I'll follow up with you. That's great. Thank you.
Please.
Thank you so much for your great presentations, really informing. Nihal Mohammed, Mount Sinai too. My question is about health disparity in the healthcare system. There is huge disparity in guidelines, concordant care, and also potential implicit biases in patient-provider communication and the quality of care patients received. So I wonder what kind of plans you guys have for addressing this aspect of disparities, and if you have current efforts that address this area, please let us know how much you have achieved in these specific areas.
I think it's a great question, interesting research question that I look at as well. I think I can just pull an example of when I had to speak with the Department of Medicine. They were talking to us about a prostate cancer patient, a twin. His twin brother had aggressive prostate cancer, and he had 7 years of back pain, multiple ED visits. And they always thought it was something else rather than just checking to make sure there was a PSA beforehand. This permeates through all our systems, and the discussion was always about the system, and I just had to bluntly say that's us, like we're part of that. I think it requires prospective introspection. So that is happening for us in our department, for example. This is something that did not come from Sam Washington. It came from the CMO of our institution. So I think as we see mission statements, they also require us as systems to understand what's going on in our own backyard. So I think that I can only speak for what's happening in my own backyard, but that's prospectively being measured in a pre-implementation phase right now. I'll put it that way.
Great session. Kyle Richards from University of Wisconsin. And I'm really interested in gender disparities in bladder cancer, and I know you guys kind of touched on it. And bladder cancer is one of the few cancers where women have worse outcomes than men. Most cancers, it's the other way around. And I'm just curious, with such a diverse panel, what do you all think are the drivers of that in women? Is it, I know there's multifactorial, but is it, genetic, biology? Is it obviously a combination of things, but?
Can you hear me? Is this on?
Yeah, I
Yes?
think so. Yeah.
So I can't necessarily speak to outcomes. Maybe one of the clinicians here can speak to that, but there are some genetic differences that we have uncovered in the germline and in the tumors that have been observed. So in our GWAS, we recently published a difference between germline variants in FGFR3, stronger association in women than men. And it seemed like that also translated to the tumors, but we don't know for sure what that means or if that is meaningful. And I just wanted to take this opportunity to say that sometimes when we see, so the other difference that is observed in tumors are KDMA6, KDM6A mutations are more common in women than in men. And again, we see that in our tumors too. But we actually don't know, when we only have that information in the tumors and it's not nested in an observational study, we don't know if the true risk is higher in women and in men. So when we just compare cases, it could just, the effect you're seeing could be because the men have fewer mutations, or it's because the women have more mutations. Without having controls, we don't know if that results in a true difference in risk. So I would say we've observed some differences, but I'm not sure we fully understand them yet.
I was going to see if Dr. Williams has anything he would add. Sorry to call you.
No, that's okay. I mean, it's important, right? Because I think it's multifactorial, as most things are. It's not isolated genetics but it's recognizing. Although women have a decreased incidence, when they do present itself, may present with more aggressive disease. Now, is it under-recognized, under-diagnosed? I think us as urologists, we tend to get the eggs for 3+ years for hematuria, then come to us and they have unfortunate, more aggressive disease that you wonder why wasn't this patient referred sooner. However, there's also biological underpinnings that does present itself when it does present more aggressive phenotype and genotype. So I think those are things that we need to better understand. And then sooner referrals, how do we go about doing so? It's our job, in our organizations, whether our primary care colleagues, myself too, as a chief medical officer here, at our campus, is just understanding at-risk populations, setting up to and leveraging technological tools that we have at our disposal, whether that be an AI algorithm, to understand, patients that have, more than one UTI, particularly in a female that may have hematuria, as perhaps an earlier prompt to referrals to a specialist when it is in fact not already done so. Those are value-added assets that we need to deploy across our healthcare continuum. So just some few ideas, that I think we can currently leverage, better understand, and then really, disseminate this important work so it's easily understandable across all stakeholders.
Hi, Bob Schreiber, patient and patient advocate. Just wanted to thank you all for a wonderful session on a very important topic, and thank you especially Dr. Washington for sitting in on the survivorship task force meeting. And I just wanted to bring that up because you work at the same institution as one of the co-leaders of the task force, and I was trying to think of ways that we as patients and patient advocates can participate in helping with equity, with patients that are dealing with all kinds of problems. And so I thought maybe you could speak to the survivorship aspects of it, and you're working with like Christina Amodi and Mary Dunn, through that task force. I would also invite patients who are interested in joining the task force, a very important way to help out. Thank you.
I would totally endorse involvement with the task force. Christina and I work obviously in the clinical space together. Oh, I see her. Thankfully, she's here. Great. But I think also it is something, at least where I work, that's part of the mission and the core. So even when it comes to my junior role in leadership within the Cancer Center, we're tasked with making sure that it is not just us in our academic silo that are setting the priorities and where the interest lies, and making sure that there is a voice of patients and patient advocates, even when it comes to our research symposia and what research is being prioritized for our internal grant mechanisms. So I think those are ways in which we start to break down these artificial impermeable barriers for knowledge and communication and collaboration. But that is something that I can speak to as an institutional priority. And I think that's where it has not maybe been as strong past couple decades.
Hi, I'm Doug Capiello. I'm actually a retired ophthalmologist and a BCAN patient advocate. And I think this is all really fascinating work. I find demographics really fascinating. I'd like to take this opportunity to put in a little plug for some of the advantages of IT-supported integrated delivery systems. And I think it was you who showed a slide early on about the VA, or I know someone showed a slide about the VA. And the disparities that you're seeing out in the community seem to disappear there for the most part, and the outcomes are similar. If I remember that slide correctly, there's so many slides that were shown. And I remember I retired from Kaiser Permanente, which you're probably familiar with, and we're similar in a way, an IT-supported integrated delivery system, and we reported all of our cancer screening rates and all of our quality rates by demographic group, and we held all of our physicians and providers accountable for that. So as an ophthalmologist, if I had a patient come in who needed diabetic retinopathy screening, that's expected, I'd get it. But if that same patient was due for a mammogram or a pap smear or some other quality measure, I was considered responsible for getting that. And so we were able to close a lot of those demographic gaps by doing so. And I agree, it's a closed system. So we have all the patient records. It's very different than kind of a network model. But there are some advantages to that, and I think you can close those gaps. And I'm just wondering if maybe at some point in time you can study some of the other integrated delivery systems to see if they're actually doing what I think they're doing.
Dr. Williams, did you want to say anything just about the VA and some of that? Don't have to.
Sure. No, yes. No, thank you. And it's, really important work actually has been brought forth by particularly the Kaiser Permanente group at large. And then I've had the wonderful opportunity of extending and working, with the VA health system. And that being said, too, equal access or an equal access center doesn't always mean access to care within the VA as well, and alludes to certain variables that may pretend to not equal access, whether or not be transportation, issues like that. But they have made concerted efforts, as those of us that have worked at one point within a VA, setting up transportation, housing to get their care is critical. And we can learn a tremendous amount, from that equal access system, but all of them at large. We're now exploring, interrogating our data. As I said, we made, perhaps one of the largest bladder cancer databases from an equal access system to really interrogate, and now not myself, but passing on to other investigators their ideas as well to help support and understand, particularly the areas that you mentioned. It's really an exciting, time. We also have tissue linked, with patients, so we're also trying to understand biological underpinnings and differences. And really, as I see it, merging health services research with biological, which will add to our granularity and understanding.
And I would just caution that even with the data that we have, we've got decades showing it's not complete or comprehensive. So there are opportunities to measure more. I know within our institution, I guess I can talk about it now, we are actively measuring some of the other factors, so financial toxicity, transportation burden, food insecurity, because I don't confidently know how many of my patients are dealing with these issues unless I'm specifically asking. Nor do I know for all of our patients in clinical trials within our catchment area, within our region, what that burden is. So now we've been tasked with internally prospectively measuring and then working with the community to evaluate interventions. So we're not coming in with a solution, but we are understanding what the problem is in our own space. So I think it is a ripe area for more action.
Hi, I'm Rick Bangs. I'm a patient advocate, and I think some of you know that I have worked at SWOG. Some subset of you probably know that I've led some of the diversity, equity, and inclusion work at SWOG. So I wanted to respond to the how do we improve question that Petros asked, and the question regarding what patient advocates can do. And sometimes I find that it's really the fundamentals that are being missed, and I'm a business guy. And so to me, a fundamental is you can't manage what you don't measure. And so one of the questions I think we need to ask is, how are we doing? How are we doing at the site level? How are we doing at the institution level? How are we doing at the committee level? how are we doing at the network group level? Okay, and I'm using the NCTN as the specific example, because frankly, we don't have a lot of this data. Okay, it's not there. All right, well, it's there, but nobody's looking at it. Okay, and we can't make progress if we're not measuring, and we can't be intentional unless we're setting forecasts and comparing the forecast to the actual. And so I would suggest, as patient advocates, we need to ask, how are we doing? What is the forecast, and what's the plan to reach the forecast? Because when you ask those three questions and dig a little bit into it, you're going to find the answers are very, very revealing. And hopefully we get better and better at this. And we have good intentions around this, and there's been great conversation about this. But in order to get traction, we've got to get the fundamentals under control, and forecasts and plans are part of that.
Thank you. Any other questions? Okay.